Je suis petite. Bonjour à tous. Je voudrais d'abord remercier Florian Scotté de ta confiance et de m'avoir demandé d'intervenir ici et de porter la parole.
Many thanks for thanking me. Many thanks for inviting me. I didn't think twice about accepting because I trusted Florian. When I saw the subject matter, I decided, oh my goodness, how am I going to manage this? Well, you have 10 minutes to define nausea. Okay, that's a tall order. How could I possibly do that in just 10 minutes? But I like him, and so here I am. I'm a former patient. Former being the operative word. I was sick 15 years ago, and let me say, never again. I had breast cancer. I have a blog. I provide information on breast cancer. It's been going on for 5 years. I'm also involved in various organizations, anti-cancer organizations, and I'm also a member of various working groups, particularly from AFSAS, and also more recently I've been a member of the Patient Information Committee for the HAS authority in France. I like this drawing. It's a drunken boat. People ask me whether I remember what it was like to be under chemo. Well, and nausea induced by chemo. I remember mostly the nausea from pregnancy. And also sometimes I drink a little too much and I get nauseous, but that's what I remember. And I assume that for those of you who have children, you remember nausea from the first trimester. And I'm sure that you, gentlemen, have probably drank a little too much or once or twice. But let me tell you, this kind of nausea is very different than chemo-induced nausea. Let me tell you, it's an entirely different ballgame. You want to die. You're in bed and you're thinking, I will never ever drink again. That's how bad it gets. Well, let me tell you, that's very different than chemically induced nausea and vomiting. So when we're diagnosed and they administer chemo, we know that we know what's going to happen. We know we're going to lose our hair. We know about the nausea. We know about all of these unpleasant side effects. And when Florian asked me to work on nausea, we'd already worked on fatigue previously. And the outcome of our work with patients has been published in this magazine. You'll have a copy, I think. And we had a method. I had asked the patients to define fatigue, and we had dozens and dozens of verbatims, extraordinary testimonials, and patients managed to put words on words. And I thought, okay, we're going to do the same for nausea. It's going to be simple. In actual fact, nothing happened. My patients, my female patients, most of my patients had breast cancer. And so they had a really hard time. They were at a loss for words. They could not put a name on nausea. They talked about a lot of things, about other adverse effects. I never talk about side effects because, let me tell you, there's nothing lateral to it. It's not a side effect. It's an adverse effect. And so there was a lot of talk about how the patients tried to counteract the nausea, what they did about it, but they had a really hard time defining the nausea itself. So it's an adverse effect that is completely invisible. It's hard to quantify. You can't say, yes, I retched, I felt sick, I threw up 3 times after the chemo, but nausea is very hard to quantify. And patients are fatalistic about it. So they know it's going to happen and there's nothing you can do. And yet, it's extremely debilitating. There's a lot of talk about quality of life. It's a word that is used and misused in France. Quality of life is absolutely key. It is so important. And let me tell you that when you're nauseous, everything is harder in your daily life. And also in your work, because it's hard to go to work. And also in terms of your social life, your entourage, your loved ones are completely helpless to help you. And also from a medical point of view, this means that you don't eat anymore, or you don't eat properly, and you discontinue the treatment, and that's bad. There's been a lot of talk about treatment observance, treatment adhesion, the compliance with the treatment. I like that word better than the term observance. Patients sometimes discontinue the treatment because of the nausea. So I'm going to let the interpreter translate the quote from that cartoon. Well, personally, I tolerate my patients' side effects quite well, said the doctor. How kind of him. There have been a lot of studies. Florian was supposed to talk about them. A lot of studies that show that professionals underestimate nausea, particularly delayed nausea. You can probably look them up. I tried to look them up, but I didn't have time. So it's a big problem. Professionals tend to underestimate or misestimate nausea, and it's bad as for any adverse event, and it's a communication problem. When two human beings meet, the key factor is communication, isn't it? And so there's a receiver and an emitter. So information going from one individual to another. And when the patient discusses nausea or any other adverse effect, well, the information has to get across to the receiver, to the physician, the healthcare professional. And the thing is, meetings are staggered. Meetings with the physician are staggered, usually every 2-3 weeks, and we tend to forget the bad things that happen. We tend to forget when we had the nausea, at what time, what is it that triggered it, and it's a big problem because we tend to forget the unpleasantness. And maybe there are tools that professionals can use to collect testimonials from patients. So the antiemetics prescribed have equally undesirable effects. So my patients had a hard time putting words on the word nausea. And she said, okay, they prescribed cortisone. I couldn't fall asleep. I was supposed to ban salt in my diet. Nobody told me. Let me tell you, the headaches. They forgot to tell me that Kytril causes less headache than Zofral, etc., etc. So it's really complicated. You find yourself caught in an apparatus. They administer a drug. This causes nausea. You gain weight. You have headaches. You can't sleep, etc. And also, there are very few other remedies. That is, other people you can talk to, professionals you can talk to. They are undertrained. There's a lot of talk about the GP being at the heart of patient care. Well, GPs and pharmacists should be looped in systematically, but let me tell you, they can be really helpful in case of adverse effects such as nausea. So my patients told me little things they do. They try to MacGyver it, quote unquote. So what do they do to remedy the nausea? Well, Coke, Pepsi, iced tea, sherbets, that is fruit ice cream, fruit or a lemon juice, a banana, herbal tea, ginger, mint, rhododendron. I heard that it works. Go figure. And also, they try to remove bad smells. They try to have smaller meals, but more often. And they try to eat 4 or 6 hours before the session, not after. And also, alternative medicines. And the cow says it's ridiculous, but effective. So they tried all kinds of alternative therapies: acupuncture, homeopathy, relaxation, hypnosis, meditation, fasting. In France, there's a lot of talk about fasting, the fact that chemo is much more effective if you're fasting. Just imagine that in those cases, it is important for the patient to get as much information as possible. They will sort out this information, but it's hard to exercise critical thinking. So these practices are all well and good, but they're mostly available in an urban setting, in a private practice, and they're expensive. And these professionals, these alternative medicine professionals, may not be trained in cancerology. Some homeopaths are properly trained, but if you find them in the yellow pages, how can you tell whether they know the different agents and they're not up to scratch? So it's no wonder some alternative medicine professionals simply don't pass muster. So I'm part of an AFSOS cancer research group, and we look at that, how to assess alternative medicine practices. And also, patients see this as soft medicine, but just because the medicine is soft doesn't mean it doesn't work. Phytotherapy, in particular, plants, all of these things, they work. And also, patients, they're afraid to talk about it. They're afraid to talk about nausea or about alternative medicines to their doctors. So how can the doctor confirm or infirm whether or not this particular remedy makes sense? So nausea-free chemo, is it possible? First of all, we need to listen to the patients. Not just listen to what they have to say, but hear what they have to say. And also we need to adjust the dosage. Patient-reported outcomes are also very important. There's a lot of talk about it. No wonder. There's an app called iChemo Diary MSD. It's available on the Apple Store. It was created by the MSD lab. It's an app which is really well designed, in my opinion, because it tracks down the adverse events, and the patient enters this information in real time right after feeling the effects, but not too late. And so the patient shows the diary to the doctor, who can keep track of exactly when the chemo, when the nausea happened, under what circumstances, etc. Otherwise, it's hard to keep track if you only see your cancerologist every 3 weeks. So AFSOS benchmarks should be disseminated to professionals and to patients. This is work we're doing at the moment. We are translating, communicating this information, the AFSOS guidelines, so as to show patients that, yes, it is available. There is such a thing as support care, and it's going to help them manage both nausea and other adverse events. It's well established. So we need to discuss alternative complementary medicines. You need to reach out to the patients and tell them, yes, there is such a thing. It is possible. There are remedies. There are tricks out there, recipes, and not just drugs. And also we need to communicate about the unwanted effects of treatments and the other treatments as well. Antiemetics, well, they cause other side effects as well. And also we need to train private practice professionals. And needless to say, I would like to send my love to the victims of the terror attacks as well as to their families. Thank you for joining me. We have time for a couple of questions or comments. So when you ask questions about nausea and vomiting, you didn't get an answer. I did get answers, but I had asked them to define nausea, and the only words I got was wretch attitude. Yeah, they called it the wretch attitude, R-E-T-C-H. And I asked them, were you properly managed? And I didn't get any response. That was kind of weird. But that was in the beginning. What about later? When you reached out to your patients, did things change? Not really. Because the clock was ticking, I went back and saw them. There was a lot of talk about alternative medicine and also the whole MacGyver system. So I let them talk. I let them talk to each other because I think it's really important. Peer experience. And I didn't go back and see them because I didn't have time. But I think I really need to. Any other comments? Well, thank you very much. Can you hear me? I'm a pharmacy doctor at the Antoine Béclair hospital, we set up a therapeutic education program for cancer patients who are being treated with chemo or not. And so we have set up group sessions around GI problems and physical activity suited for these problems. And so feedback from patients is excellent. And we're also setting up a partnership between hospitals and private practices. We have a partnership with the Osmosis healthcare network. So we welcome patients from our hospital, but also from the entire region. And also we have a partner with pharmacists so as to provide them training. So pharmacists, but also GPs, how to manage cancer. That's the goal of the training. Oh, that's great, because a major issue over and beyond the chemotherapy-induced nausea and vomiting is how do you coordinate between the hospital doctors and the private practice doctors, and new targeted therapies now being administered in a private practice setting. So I believe that GPs really have a role to play, private practice physicians really have a role to play, and so coordination between hospitals and private practices is absolutely key. And pharmacists have yet to find their rightful place in terms of cancer management processes, and they can't miss the boat because these are primary care health professionals. A pharmacy, that's the only place that is open all day long, and you don't need an appointment to go see your pharmacist. So in terms of therapeutic education, let me say that it's very, very important. The only problem with therapeutic education is that patients say that they don't want to go back to hospital. It's complicated. You got to mix it up with something else, maybe a meeting with a cancerologist or chemotherapy, and that's a bit tiring. And the other thing, when they come back specifically for therapeutic therapy, transport is not taken care of. Well, cancerologists provide transport vouchers, so it's paid for. Oh, I'm happy to hear that. Yes, yes. And so outside of my chemo courses, we tend to go back quite often, and it's paid for using transport vouchers. Thank you very much.